So today we will discuss about the antidepressant drug, the latter part of the CNS chapters. This antidepressant drug, antipsychotic drug, drugs for bipolar disorder. These are complex chapters you need to understand. Okay, we will discuss about in details. So what is depression? Major depressive illness. This is known as major depressive illness. Usually the depression are unipolar disease. That is, there is only depression, but there are some bipolar depression also. That is, in some times there is depression, in sometimes there is mania or euphoria. That is in the opposite spectrum of the depression. So we have to treat the depression accordingly. And also depression is associated with some other features, like there may be some psychotic depression, there may be some atypical depression, and accordingly we have to use the different drugs in combination. So firstly, this depression is an affective disorder, and depression mainly happens due to the deficiency of noradrenergic and serotonergic transmission system in the neurotransmitter. So what happens when we are using antidepressant drugs? It has been seen to increase the availability of norepinephrine and serotonin as neurotransmitter in the synaptic cleft. And in the long term, when we are continuing using the antidepressant drugs, there will be some adaptive changes, so that there will be more and more these neurotransmitters, monoaminergic neurotransmitter, that is the norepinephrine and serotonin, will be available in the synaptic cleft. It has been seen. So basically our motto is to increase this availability, and this can be done by blocking the reuptake. So you know about the metabolism of the norepinephrine, serotonin, etc. These are secreted from the synaptic vesicles in the neuroptic cleft, synaptic cleft, and some part, most part of it is reuptake back to the neurons, and this is done by reuptake transporter known as the norepinephrine transporter NET and serotonin transporter SERT. So if we are blocking this norepinephrine transporter or serotonin transporter, ultimately there will be less reuptake back of these neurotransmitters. So these monoamines, these are the monoamines, norepinephrine and serotonin, will be more available for its action on the neurons, postganglionic neurons. So ultimately that leads to antidepressant effect. And it has also been seen that if we are continuing using this, there will be increase of the brain derived neurotrophic factors. So these are different types of the nerve factors. That is, if these are also increased, there will be remission of the depression. So let's just start. So it is a mood or affective disorder. Already we have seen approximately 15 to 20% of individuals have a lifetime risk of depression. And this is also true that if we are treating the depression, approximately 20% will not respond. So in those cases, in resistant depression, we have to use the newer drugs, we have to use the combination of the drugs. So changes in the mood are associated with depression and or mania, and disorders of the mood rather than disturbance in thought or cognition is the main important part of this depression. That is disorders of the mood. Clinical depression is usually if the symptoms are continuing for more than 2 weeks. So these are the symptoms of the depression, like emotional symptoms, intense feeling of sadness, hopelessness, despair, inability to experience ordinary pressure, feeling of guilt, ugliness, indecisiveness, loss of motivation, loss of energy and interest. So these are the different types of the symptoms. There may be some biological symptoms like retardation of thought and action, loss of libido, loss of appetite, sleep disturbance. And this depression is also one of the most common cause of the suicide, and approximately again 15 to 20% patients at some point of time in their major depressive illness may try suicide. So symptoms of the mania are just opposite of the depression. So here mania means euphoria. The patients become euphoric, happy, excited, sudden odd decisions may be taken, excessive rapid talking, moving quickly from one to another. This is known as the flight of ideas. Hyperactive, full of energy, unable or unwilling to sleep, sudden irritability, rage, paranoia, impatience, aggression, all these are mania. So this is just in the opposite spectrum of the depression. If we consider it as a scale, if 0 is the depression, 100 will be the euphoria or mania. So in many patients there will be cyclical change of the depression and mania, and in those cases we have to treat similarly in those cases. So there may be mild depression, moderate depression and severe depression according to their duration of the depressive episodes. Unipolar depression, what I am talking, usually there is only major depressive episodes, while in case of the bipolar depression there is depression as well as the mania, it alternates. There may be psychotic depression, that is depression associated with some psychotic features. Postpartum depression very common after the postpartum period. Atypical depression, some features that will not be in collaboration with normal depressive illness. So it is basically associated with insufficient central release of the norepinephrine and 5-hydroxytryptamine, already we have seen. So norepinephrine, 5-hydroxytryptamine or serotonin, these are the monoamines. There will be deficiency of the monoamines in general. So ultimately that led to the development of the biogenic amine hypothesis. So depression, how depression happens, usually we have seen that if we are using these drugs there will be improvement of the symptoms. That is why depression can be considered as a myogenic amine deficiency. So this is also known as the monoamine theory of the depression. So this was proposed in the 1965. So ultimately it states that depression is caused by functional deficit of monoamine transporter at certain sites in the brain, like deficit in amount and function of the cortical and limbic serotonin, norepinephrine, and in some cases dopamine, while mania results from functional excess. So basically it is a monoamine hypothesis. The theory is based on the ability of known antidepressant drugs to facilitate monoaminergic transmission as drugs and as reserpine to cause depression. Reserpine causes depletion of the monoamines. Already you have seen depletion of the monoamines. So it has been seen that if we are using reserpine, that leads to depression. So all this theory ultimately leads that there may be some deficiency of the monoamines, that is why there will be depression. So you can see this is the neurotransmission, how it happens. Action potential comes, this is the presynaptic terminal, this is the different monoamines that is present within the synaptic vesicles. There will be more calcium entry within this when the action potential comes, and this will be released, and this released neurotransmitter acts on the postsynaptic receptor and different responses happens. So usually if there is normal synapse, there is no depression. You can see the red ones are different types. These monoamine neurotransmitter, these are quite abundant. So this, some part of it is reuptake back, some part is metabolized by the monoamine oxidase, that is the MAO enzyme. Okay. So if there is deficiency, there will be less red ones, that is there will be less monoamines, there will be depression. So 5-HT deficiency or serotonin deficiency may cause the sleep problems, irritability and anxiety associated with depression. Decreased level of the norepinephrine, ultimately this regulates the mood, alertness, arousal, appetite, reward, drives, etc. and it ultimately contributes to the fatigue and depressed mood of the illness. In some cases dopamine is also contributes some part, but in most of the cases this serotonin and norepinephrine are the main part that plays in the pathogenesis as well as the treatment of the depression. So on the derivative of this also comes another theory, that is the neurotrophic hypothesis. Here the brain derived neurotrophic factor, which is an essential part for the neurotrophy, the development of the neurons, that will be deficient in the depression, and again it is associated with the loss of this neurotrophic support. We have seen that if we are continuing using the antidepressants, that ultimately leads to more availability of the monoamines, that ultimately leads to more availability of this brain derived neurotrophic factors also. So ultimately we can say that this monoamine theory as well as the neurotrophic hypothesis, both these are related to one another, and if we are treating this depression with the antidepressant drugs, that ultimately helps control of both of these hypotheses. So ultimately how we are treating the depression, psychological treatment, there are different types of the psychological support, behavioral therapy are there. Apart from this, pharmacological treatment is the most important. Approximately 70 to 80% depressed patients respond to antidepressants, and if it is not controlled, in some cases electroconvulsive therapy is also advocated. So now first coming to the pharmacotherapy. So firstly you need to understand that antidepressants usually do not act rapidly. There are some drugs that may act rapidly, antidepressant like mirtazapine. Apart from this, in most of the cases we have to start antidepressants and wait for minimum 2 to 4 weeks for its result to be manifested. So ultimately how it happens, when we are using the antidepressants, immediately there will be more availability of the monoamines in the neurotransmitter, but again there will be some more upregulation of different types of the receptors. When we are continuing using the antidepressants for weeks, ultimately there will be some adaptive changes, there will be down regulation of different receptors that also causes reuptake, as well as the increase of the neurotrophic factors like brain derived neurotrophic factors. All these three ultimately leads to some adaptive changes and ultimately the antidepressant effects are manifested. That's why in spite of antidepressants are increasing the monoamines in the synaptic cleft immediately, usually the effects usually take 2 to 4 weeks to be manifested. The most consistent adaptive changes seen with antidepressant drug is the down regulation of the beta receptor, alpha 2 receptor, 5-HT2 receptors. Usually the alpha 1 is not affected. So when we are continuing using the antidepressant drug, there will be down regulation of these receptors, beta, alpha 2, 5-HT2 receptors. Usually affect only people who are depressed. When we are using this in normal persons, usually there will be some fatigue sensation, but usually that will be an unpleasant sensation, but ultimately it helps those who are depressed. Effect does not increase with increasing doses usually. Antidepressants usually are not habit forming. The older antidepressants like tricyclic antidepressants are somewhat habit forming, but newer ones are not. Antidepressants differ widely in side effects, and side effects mainly develop due to their non-specific activity, that is they are blocking also other receptors. That's why there will be different types of the side effects. So these are the classification of the antidepressant drugs. First is the tricyclic antidepressants and the derivative newer one is the tetracyclic antidepressant. Within the tricyclic antidepressants, the common ones are the imipramine, clomipramine, doxepin, amitriptyline, trimipramine, desipramine, nortriptyline. These are the tricyclic antidepressants. Tetracyclic antidepressants are the amoxapine and maprotilline. Monoamine oxidase inhibitor, the next group. Example is trancypramine, phenelzine, and the newer ones is the Moclobemide. Next, coming to the selective serotonin reuptake inhibitors, SSRI. These SSRI are now the first line drug for the treatment of the depression. Example of the fluoxetine, this is the first discovered, fluvoxamine, Sertraline, paroxetine, citalopram, escitalopram. These are the selective serotonin reuptake inhibitors. The fourth one is the serotonin and norepinephrine reuptake inhibitors or SNRI. This is also used as one of the first line and in several other conditions. Example is Venlafaxine, Venlafaxine and Duloxetine. This comes under the SNRI. Apart from this, there are some atypical antidepressants or the newer antidepressants that act by myriad mechanisms. For example, serotonin antagonists and reuptake inhibitors like SNRIs, like nefazodone, trazodone. Another one is the norepinephrine and dopamine reuptake inhibitor like bupropion. Noradrenergic and specific serotonergic antidepressant like mirtazapine. Noradrenaline reuptake inhibitor, reboxetine. Serotonin reuptake enhancer, tianeptine. These all can be considered as a miscellaneous or atypical antidepressants. The major groups are the tricyclic antidepressants, the newer ones is the tetracyclic antidepressants, monoamine oxidase inhibitor, selective serotonin reuptake inhibitor and serotonin and norepinephrine reuptake inhibitors, SNRIs. These four are the main groups and these are the different atypical ones. This also same thing, different atypical antidepressants. Example is trazodone, mianserin, mirtazapine, bupropion, tianeptine, amineptine, atomoxetine, etc. This acts by different other mechanisms by blocking different other receptors. Now first coming to the tricyclic antidepressant. This is the oldest class of the antidepressant drugs. They have characteristic 3-ring nucleus. You can see this is the 3-ring, that's why it is known as the tricyclic. The first tricyclic antidepressant was the imipramine. Imipramine is the first tricyclic antidepressant that was discovered. So these are the other tricyclic antidepressant already you have seen like clomipramine, nortriptyline, trimipramine, desipramine, amitriptyline and doxepin. Tetracyclic antidepressants are the newer ones. There is another ring, that's why tetracyclic like maprotilline and amoxapine. So mechanism of action of the tricyclic antidepressants, so basically all these tricyclic antidepressants block the reuptake pumps. Already you have discussed reuptake pumps means norepinephrine reuptake as well as the serotonin reuptake. So there is reuptake pumps of both 5-hydroxytryptamine of serotonin and norepinephrine in nerve terminals by competing for binding site of the transport protein. So ultimately that leads to increased concentration of the norepinephrine and serotonin in the synaptic cleft. So that will be more available at the receptor site also. So that leads to facilitation of the norepinephrine and serotonin transmission and improve symptoms of the depression. So ultimately some have more potency for inhibition of the serotonin and some have more potency for inhibition of the norepinephrine pumps. That is, different agents basically have different potency against these different pumps. For example, clomipramine, imipramine, amitriptyline blocks more serotonin pumps, nortriptyline, desipramine blocks more norepinephrine pumps. So this is the mechanism already you have seen. So this is the release of the monoamines, norepinephrine and serotonin, and most part of it is reuptake back, and this reuptake is blocked by the tricyclic antidepressants. So the blocking of the tricyclic antidepressants, apart from this also blocks several other receptors also. That's why these are non-specific blockers, and that ultimately leads to different types of the adverse drug reaction. Because this also blocks some other serotonergic receptors also, different alpha adrenergic receptors, histaminic receptors, different muscarinic receptors. They also block different other receptors. So ultimately this all leads to more and more adverse effects. That's why tricyclic antidepressants are lesser used nowadays, mainly in case of the depression. So you can see that what are the pharmacological actions when we are using the tricyclic antidepressants or other antidepressants. They ultimately elevate the mood, improve mental alertness and increase physical activity. Already you have seen it takes minimum 2 to 3 weeks for its effect to develop. In non-depressed patients, they may cause sedation, confusion and motor incoordination. So reuptake block occurs quickly, but antidepressant effect develops after weeks. Already we have discussed. Why? Because it needs some adaptive changes in the neurotransmitter level, in the receptor level. There will be some down regulation of alpha receptor, beta receptor, some other serotonergic receptors, and these adaptive changes takes usually weeks. And these adaptive changes also leads to more availability of the neurotrophic factors like brain derived neurotrophic factors. That's why even if these antidepressants possess the availability of the different monoamines immediately, the antidepressant effect usually takes 2 to 3 weeks to develop. Certain adaptive changes, like already you have seen, initially the presynaptic alpha 2 5-HT1 receptors are activated, later they are desensitized or down regulated. Net effect is enhanced norepinephrine and serotonin transmission. So ultimately after the 2 to 4 weeks there will be continuation of the enhancement of the norepinephrine and serotonin transmission. So peak levels, pharmacokinetics, usually 2 to 6 hours post ingestion. Usually most of the these antidepressants are given once daily dose. They are lipophilic in nature, they are well absorbed from the GIT, their volume of distribution is also very large. Usually hepatic oxidation by which it is eliminated. They are metabolized in the livers to some other active drugs also, some product to active drugs like imipramine is converted to desipramine, amitriptyline to nortriptyline, etc. and they are also active. So they are strongly bound to plasma proteins. Average half-life is approximately 24 hours or up to 72 hours in overdose. They have very large half-life and large volume of distribution. That's why if there is poisoning with tricyclic antidepressants, this will be difficult to treat because the dialysis will not remove all of the tricyclic antidepressants from the body because it enters within the tissues. That's why the volume of distribution of tricyclic antidepressant is very high. And they have also narrow therapeutic index. That is, therapeutic index is quite narrow. If it is less, there will be subtherapeutic effect, the patient will be more tendency for suicide. If it is more, there will be some toxicity, tricyclic antidepressant toxicity may happen. So the side effects mainly happens due to the blockade of the other receptors. Already you have seen like alpha 1, H1, M1, 5-HT2 receptors. So anticholinergic side effects happens because they are blocking the muscarinic receptors. Different types of the anticholinergic side effect, like there may be dry mouth, bad taste, constipation, epigastric distress, urinary retention, especially in elderly when their prostate is already enlarged, blood vision, palpitation may happen. So this is the most common adverse effect of this antidepressant, mainly the tricyclic antidepressant. Anticholinergic side effect because they are blocking the different muscarinic receptors. There may be sedation, mental confusion, weakness because they are blocking the histaminergic receptors. That's why there will be some sedation. With amitriptyline and more sedative congeners, there will be more. Increased appetite and weight gain happens. Some patients receiving any antidepressant may abruptly switch over to dysphoric agitated state, though this may happen to mania. Because we do not know whether the patient is suffering from unipolar depression or bipolar depression. The patient comes with depression for a long period of time, but there may be some history of mania. That's why history taking is important. So if we are using the antidepressant drug in those bipolar depression patients, the patient may switch over to dysphoric state or manic state suddenly. So in those cases, we have to treat that condition also. There may be sweating and fine tremors. Seizure threshold is lower, that is there will be epileptogenic potential, the patient may land up to epilepsy in some cases. Since these drugs also blocks the alpha receptors, so there is chances of the postural hypotension. হঠাৎ করে ওঠার পর মাথা ঘুরে যেতে পারে, that's why in most of the cases this is given in the bedtime, especially in older patients. This is desipramine. But remember, there are some antidepressants that causes more euphoria like state. This would be given in the morning, and most of the cases some antidepressants causes some sedation. This would be given in the night. There may be some sexual distress, there may be delay or interference with erection, ejaculation, occasionally to orgasm. Sexual dysfunction is quite common. The patient may complain when they are continuing with some antidepressants. There may be some cardiac arrhythmias because some STT segment changes happens. Arrhythmia that may be responsible for sudden death also in some patients. Amitriptyline and dosalapine are particularly dangerous in overdose because that may leads to the arrhythmia. Higher incidence of the arrhythmia is reported in them. So these are the different adverse effects of the tricyclic antidepressants. So if we are asked what are the adverse effects of the antidepressants, tricyclic antidepressants mainly adverse effects are mainly due to the blockade of the other receptors. So they are blocking norepinephrine transporter and serotonin transporter, that is okay. But they are also blocking alpha receptors, that's why there will be postural hypertension. They are blocking muscarinic receptor, that's why there will be different types of the anticholinergic side effects from the dry mouth to the retention of the urine. They are blocking the histaminergic receptor, that's why there will be sedation, mental confusion also. They also decrease the seizure threshold, so there will be more chances of the epilepsy. In bipolar disorder, in bipolar depressive illness, if we are using this antidepressant, there will be sudden switch over to the dysphoric state or agitated state or manic state. There may be some arrhythmia-like state, there may be some ST wave changes, so the patient may land up to sudden death also. So this may happen with the tricyclic antidepressants. So acute poisoning of the tricyclic antidepressants ultimately leads to this type of adverse effects. Acute poisoning, that is the patient have taken more number of the pills, more number of these tricyclic antidepressants together, mainly for the suicide purpose. So frequent, usually self-apprehended by the depressed patients and may endanger life. Manifestations are excitement, delirium, different anticholinergic effects. This is similar to that of the atropine poisoning because the atropine is also anticholinergic drug. There may be some muscle spasm, convulsion, the patient may go to the coma. Depressed respiration, low blood pressure, ventricular arrhythmia may happen. So firstly, if the patient land up with this, we have to do some gastric lavage, supportive treatment, support to the heart, support to the respiration, fluid infusion, maintenance of the blood pressure, body temperature is to be done. Acidosis is usually happens, that's why it is to be corrected by the bicarbonate infusion. Diazepam, already you have read, sedative hypnotic drug is the diazepam. That is usually done for the convulsions as well as the delirium. That usually happens when there is overdose with tricyclic antidepressant. So most important is the treatment of the cardiac arrhythmia. Cardiac arrhythmia can be treated by this bicarbonate also as well as the propranolol or lidocaine may be needed in some of the cases. So this is the acute poisoning of the tricyclic antidepressants and how it is treated. These tricyclic antidepressants also have different drug and drug-food interactions. So they are strongly bound to plasma proteins. So some other drugs or foods that displace it from its plasma protein binding sites that can land up to the poisoning like state, like aspirin or phenylbutazone. Tricyclic antidepressants are metabolized by the liver microsomal enzymes. Again, some drugs, if they are blocking the cytochrome enzymes or they are enhancing the cytochrome enzymes, so there will be ultimately induction or inhibition of these drugs also. So you can see their effect can be reduced by inducer of the liver microsomal enzyme like barbiturate. Barbiturate is a liver microsomal inducer, while its effect can be potentiated by inhibitors of the cytochrome system like oral contraceptives and some other antipsychotics, some other drugs. SSRI is itself is a inhibitor of the cytochrome system. So, if we are combining this SSRI with some tricyclic antidepressant, so there may be chance that the tricyclic antidepressant concentration will be higher, and since they have low therapeutic index, so there may be some toxicity. So, tricyclic antidepressants should not be given with MAO inhibitor also. So, MAO inhibitors, so they are blocking the MAO enzymes. This MAO enzyme is also associated with the metabolism of these monoamines. So, when they are also blocked, there will be tremendous rise of this norepinephrine level. So, there may be some hypertensive crisis may happen. So, again these two drugs should not be combined together. So, you can see tricyclic antidepressant, if we are giving this with MAO inhibitor, there will be mutual enhancement of the hypertension, hyperpyrexia, convulsion and coma may also happen. If we are using this with direct acting adrenergic drugs, so there will be some potentiation of the effects of biogenic amines, some happen. And if we are using some ethanol or other CNS depressant, there will be toxic sedation. There will be more sedation will happen because this ethanol itself is a sedative. If we are using some indirectly adrenergic drugs, that also block effects of the indirectly acting sympathomimetic drugs by preventing the drugs from reaching their intracellular sites. So, ultimately again it also leads to sedative like state. So, basically it is a very narrow therapeutic index. If we are using some other drugs, that may ultimately leads to more enhancement, more hyperpyrexia, hypertension, euphoria, etc., or ultimately that may leads to toxic sedation also. So, we have to use this drug judiciously. Now, coming to the amoxapine. Amoxapine is a newer part of this tetracyclic antidepressant. This also blocks dopamine D2 receptors in addition to inhibiting the norepinephrine reuptake. So, additional dopamine receptor blocking action, amoxapine. It is chemically related to the antipsychotic drug loxapine. That is why they have mixed antidepressant and neuroleptic properties. We will read about the antipsychotic and neuroleptic drugs later. Okay. So, there may be some risks of extrapyramidal side effects, details is not required. So, the contraindication of tricyclic antidepressant, they should not be used in patients with glaucoma or enlarged prostate because of their atropine like action. Because these tricyclic antidepressants, remember they have very strong anticholinergic action. So, since they have anticholinergic action, so this should not be given in glaucoma, this should not be given in enlarged prostate because that ultimately leads to more urinary retention. These are contraindicated in manic depressive illness, already you have seen. So, bipolar disorder also known as the manic depressive illness, if we are using this, there will be sudden shift to the dysphoric state. This should not be done. Here we have to use the lithium salts, we will discuss about this. We can use the antidepressant plus some antipsychotic agents that can be used in bipolar disorder like valproate also. Okay. Next, coming to the monoamine oxidase inhibitor. So, already we have done with the tricyclic antidepressants, which is the oldest antidepressant drug. Next, coming to the monoamine oxidase inhibitor. This is also one of the oldest. That example is the phenelzine, prenylcypramine, isocarboxazide, pargylene and moclobemide, of which moclobemide is more selective, and in fact in recent days these are less used, moclobemide is more used. Again the antidepressant effect is usually takes 2 to 4 weeks. So, this monoamine oxidase is found in nearly all tissues and is located intracellularly associated with mitochondria. Monoamine oxidase, this is an oxidase that causes metabolism of the monoamines. They are present in nerve terminals that release the norepinephrine, dopamine and 5-hydroxytryptamine. They are located on the outer surface of the mitochondrial membrane. In neurons, this monoamine oxidase oxidatively deaminates and inactivates any excess norepinephrine, serotonin and dopamine that may leak out of synaptic vesicles. So, this monoamine oxidase is not involved in the inactivation of already released transmitter. So, when there is transmitter transduction, there will be some release from the synaptic vesicles and that will be mainly metabolized by this monoamine oxidase. There are two types of the monoamine oxidase A and monoamine oxidase B. Okay. So, we will discuss. Since monoamine oxidase inactivates monoamines from the synaptic vesicles. You can see this is the monoamine, they are inactivated by this monoamine oxidase that is present in the outer layer of the mitochondria. So when we are using the monoamine oxidase inhibitors that prevent the inactivation of the monoamines within a neuron, causing excess neurotransmitter to diffuse into the synaptic space. That is, already more monoamines will be there within this mitochondria, and that will be released into the synaptic cleft when we are using the monoamine oxidase inhibitor. So remember, monoamine oxidase causes the metabolism of the monoamines. What are the monoamines? Norepinephrine, serotonin and dopamine. When we are using this monoamine oxidase inhibitors, they are blocking this monoamine. So these are present in the outer layer of the mitochondria. These are mainly associated with the metabolism of the monoamines that is diffusing from the synaptic vesicles. So when these are blocked, there will be more availability of these monoamines, and that will be released from the synaptic vesicles to the synaptic cleft. So there are two types of the monoamine enzymes, MAO and MAO-B. Monoamine oxidase A is mainly metabolizes the norepinephrine and serotonin and tyramine, and monoamine oxidase B is mainly specific for the dopamine. So the inhibition of the monoamine oxidase A mainly produces the antidepressant effect, while if we are inhibits the monoamine oxidase B, that mainly produces the anti-Parkinsonian effects. So you will read later the anti-Parkinsonian drugs. There you will read about the selective MAO-B inhibitors. So there are some non-selective monoamine oxidase inhibitors that blocks both the MAO-A and MAO-B. There are some selective MAO-A inhibitors that mainly blocks the MAO-A, and there are some selective MAO-B inhibitors. It has been seen that MAO-B, selective MAO-B inhibitors, example is the Sertraline. If it is used in very high doses, that can also blocks both MAO-A and MAO-B, and that have some antidepressant effect. That is, MAO-B inhibitors that is used for the Parkinson's disease, if it is used in high doses or if it is used as a transdermal patch, that also leads to as a treatment for the depression also. Okay. So these are the irreversible and non-selective MAO inhibitors like Phenelzine, phenylcypramine, isocarboxazide and pargylene. That is, they are blocking both the monoamine oxidase A as well as the B. So they cannot distinguish between these two isoenzymes, and usually these are the irreversible ones. That's why when we are using this, the monoamine oxidase level will not return even if we are stopping the drug, and it usually takes approximately 1 month, 2 to 3 weeks for the generation of the new enzymes to be synthesized. So it is a irreversible enzyme inhibitor, irreversible as well as the non-selective. Reversible and selective inhibitor of the monoamine oxidase A is the Moclobemide, that is used for the treatment of the mild to moderate depression. It is short acting and antidepressant effect is there. And selective inhibitor of the MAO-B like Sertraline or Deprenyl, already we have seen, it is used in the Parkinsonism, and Deprenyl is used in different types of the neurodegenerative disorder. So there are different side effects of the MAO inhibitors. These MAO inhibitors, particularly the non-selective MAO inhibitors, have very high drug-drug and drug-food interactions also. So when we are using the MAO inhibition, other amines such as dopamine are able to accumulate in peripheral sympathetic nerves and displace vesicular norepinephrine, so there may be some hypotension. There are again some atropine like antimuscarinic effects here is also, like dry mouth, blood vision, urinary retention can happen. There may be some CNS stimulation like insomnia, tremor, excitement, convulsion. Weight gain may be associated with increased appetite. There are drug interactions like if we are using the opioid analgesic Pethidine. This may cause severe hyperpyrexia, restlessness, coma and hypertension. Mechanism is unclear, but it is likely that an abnormal Pethidine metabolite is produced when we are using the MAO inhibitor, particularly the non-selective MAO inhibitor, that causes inhibition of the normal demethylation pathway. That's why we should not use Pethidine as well as the non-selective MAO inhibitor. That may lead to hyperpyrexia, severe increased body temperature, restlessness, coma and hypotension may happen. Again, levodopa, precursor of the dopamine, again this should not be added with the MAO inhibitors, that can lead to hypertensive crisis. We should not use the, again it coming to the amphetamine and ephedrine. This amphetamine and ephedrine are the indirectly acting sympathomimetic amines. Already you have read this in the ANS chapter, amphetamine and ephedrine. So it can interact with MAO inhibitors causing the liberation of the accumulated monoamines. So ultimately that can lead to hypertensive crisis. Tricyclic antidepressants already you have seen, the adverse effects are more or less similar, that's why these two should not be combined. This MAO inhibitors should not be combined with selective serotonin reuptake inhibitors also, that may lead to more availability of the serotonin and serotonin syndrome can happen. Now coming to the cheese reaction with MAO inhibitor, this mainly happens with the non-selective MAO inhibitors. So already we have seen that non-selective MAO inhibitors are blocking the MAO that ultimately causes the metabolism of the monoamines. So this occurs when tyramine rich foods are taken with these MAO inhibitors. Tyramine rich foods are most common is the cheese. Apart from cheese there may be some wines are also there. So old cheese, yeast products, some pickles or smoked fish, red beans, red wine, chicken liver, sausage, they contain large amount of the tyramine. Tyramine is an indirectly acting sympathomimetic amines. Okay. So it is normally degraded in our gastrointestinal system by the monoamine oxidase, particularly monoamine oxidase A. So when we are using this monoamine oxidase with this tyramine containing food, so ultimately this tyramine will not be metabolized since the MAO is already inhibited. So they are taken up into adrenergic neurons where this tyramine is converted to another metabolite known as the octapamine. Octapamine is a false neurotransmitter which causes massive release of the norepinephrine from different synaptic vesicles. So ultimately that may result in hypertensive crisis. We know when there is more norepinephrine we are giving, there will be severe rise of the blood pressure. Severe hypertension may happen, severe headache, and ultimately that may lead to fatal intracranial hemorrhage. So this is known as the cheese reaction. So why this cheese reaction happens? Again very important. So cheese or cheese type substances like some yeast products, some beans, some red wine etc. that contains indirectly acting sympathomimetic amines, tyramine. So these are the tyramine containing foods. Now MAO inhibitor, monoamine oxidase is mainly associated with the metabolism of this tyramine. So when we are giving the MAO inhibitor, mainly the non-selective MAO inhibitor, this tyramine is also not metabolized. When it is not metabolized, that ultimately it is taken up, again it is converted to another metabolite octapamine. This octapamine leads to more rapid and more increased release of the norepinephrine in the synaptic cleft. And this increased norepinephrine leads to hypertensive crisis, there may be some stroke, intracranial hemorrhage etc. This is known as the cheese reaction. What is the treatment? Treatment is the prazosin or phentolamine, that is the alpha blocker. So already we know the prazosin or phentolamine, these are the alpha blocker. So at least 10 milligram tyramine needs to be ingested to produce this reaction. So very small amount of the tyramine will not lead to the cheese reaction, approximately 10 milligram of tyramine needs for this cheese reaction. But when we are using the Moclobemide, there will be no or very less chances of the cheese reaction, and the food and food drug interaction is also very less, the Moclobemide. So what is this Moclobemide? It is also known as the RIMA, that is the reversible and selective MAO-A inhibitor, Moclobemide. Mainly it is used in mild to moderate depressive episodes. They have short duration of action. Full monoamine oxidase activity is restored within 1 to 2 days of the stopping the drug. They causes competitive enzyme inhibition, that is when we are using this, the tyramine is able to displace it from the enzyme, that is why there is less chances of the cheese reaction. So potentiation of the pressure response to ingested amine is very minor, and dietary restriction usually is not required. So the patient can take the cheese or other items that contains the tyramine. It lacks the anticholinergic, sedative, cognitive, psychomotor and cardiovascular adverse effects of the typical tricyclic antidepressant. So all these side effects are already present in the tricyclic antidepressants, already we have seen due to the blockade of the different other receptors. So Moclobemide does not have this type of the adverse drug reaction, and it is also safe in overdose. Particularly good option in depression in elderly patients and in those with heart disease, and also in case of the social phobia. So in elderly patient with heart disease, patients with social phobia, particularly in mild to moderate depression, we can use the Moclobemide, which is a reversible inhibitor of the monoamine oxidase A. it usually does not have any cheese reaction. Dietary restriction is usually not needed. Adverse effect like nausea, dizziness, headache, etc. can happen. So the therapeutic use considered to be the last line agent due to drug-food interactions. These MAOI inhibitors in endogenous depression, atypical depression and phobic state usually is needed. So basically this tricyclic antidepressant and MAOI inhibitor are usually used if it is not responding to SSRI or SNRI, but Moclobemide can be used. Next, coming to the selective serotonin reuptake inhibitor, very important, and it is now the first line drug for the treatment of the depression. Example is the Fluoxetine, which is the first discovered, Fluoxamine, Paroxetine, Sertraline, Citalopram, Escitalopram. So these are the selective serotonin reuptake inhibitors, that is they are selectively blocking the reuptake of the serotonin or 5-hydroxytryptamine, less effect on the norepinephrine. Okay. So this is the currently most widely used class of the antidepressants. They act within the brain to increase the amount of the neurotransmitter, mainly the serotonin, in the synaptic tract by inhibiting its reuptake. SSRIs are described as selective because they affect only the reuptake pumps responsible for serotonin, as opposed to earlier antidepressants which affect other monoamine transmitters as well. Already we have discussed. Because of this, they lack the different other side effects of the tricyclic antidepressants. So they are selectively blocking the serotonin or 5-hydroxytryptamine. That's why selective serotonin reuptake inhibitors, SSRI. So you can see SSRIs also have delayed onset of action extending to several weeks, similar to other antidepressant actions, because they need some adaptive changes in the neurotransmitter levels. So blocks the serotonin reuptake pump, causes serotonin to increase mainly only in the somatodendritic area of the serotonin neuron. You can see this is the somatodendritic area, not in the axon terminal firstly. But when we are combining this, continuing this, ultimately the somatodendritic serotonin 1A autoreceptors are desensitized or downregulated. These are also causes some reuptake. So there will be some downregulation, less reuptake for a long period of time. You can see. So there will be some downregulation or desensitization. These are the adaptive changes at the neurotransmitter level. So autoreceptors downregulate, neuronal impulse flow is turned on. So ultimately there will be more brain derived neurotrophic factor is there in the axonal areas also. So both in the somatodendritic area as well as the axonal area, there will be more availability of the 5-hydroxytryptamine. So delayed onset of action extended to several weeks, same thing already we have discussed. Advantage, what are the advantages of the SSRIs over the tricyclic antidepressants? So they produce little or no sedation because they have very little H1 receptor activity, do not interfere with cognitive or psychomotor function or produce anticholinergic side effects. Anticholinergic side effects, cognitive side effects, these are very less. They are devoid of alpha adrenergic blocking action, thus postural hypotension does not occur, making them suitable for elderly patients. There will be no postural hypertension. They have practically no seizure precipitating action, that is they have less epileptogenic potential. Arrhythmias are also less, weight gain is usually not a problem. In contrast to MAO inhibitor, they do not cause the cheese reaction. Acute toxicity is also less in comparison to the MAO inhibitor or tricyclic antidepressant. That is, if the patient will take more number of the SSRI pills, there will be less chances of the toxicity in comparison to the tricyclic antidepressant or monoamine oxidase inhibitor. So these are the advantages of the selective serotonin reuptake inhibitors. So Fluoxetine, which is the first SSRI that was discovered, it is a bicyclic compound. Half-life is approximately 2 days, and if we are continuing this, the half-life increases to 4 days also. That's why Fluoxetine can be given once weekly regimen also in some of the cases. The liver metabolizes Fluoxetine into Norfluoxetine, which is a metabolite which have a longer half-life. That's why its half-life is continuously increasing when we are continuing this for a long period of time. Metabolism in usually the P450 system. It is approved for use in children greater than 7 years and adolescents, and it is relatively safe in pregnancy also. So this Fluoxetine can be used in juvenile depression also greater than 7 years. Fluvoxamine is a shorter acting SSRI with T-half of the 18 hours. Fluvoxamine is mainly now used for the treatment of the obsessive compulsive disorder, OCD. OCD usually Fluvoxamine is used usually in higher doses than the dose that is required for the depression and used for a long period of the time. Relatively more nausea, dyspepsia, flatulence, nervousness and discontinuation reaction can be seen with fluvoxamine. So remember, fluvoxamine is now mainly indicated in obsessive compulsive disorder. Paroxetine is another short acting SSRI, does not produce active metabolite. There may be some higher incidence of the gastrointestinal side effects like some nausea, vomiting can happen, sexual distress can happen, discontinuation syndrome can happen. Paroxetine is mainly also used in different types of the social phobia, OCDs, obsessive compulsive disorder, different types of the depression also. Sertraline, very commonly used nowadays. It is a selective serotonin reuptake inhibitor for oral administration. Usually sertraline does not cause any type of sedation. That's why it is given in the morning dose. It is also efficacious in juvenile depression. It is recommended for the PTSD also, that is the post traumatic stress disorder, that is also associated with anxiety. This sertraline can be given. Drug interactions are less. Plasma half-life is very high, 26 hours. Once daily dosing can be sufficient. It appears to be also a minor inhibitor of the dopamine reuptake. So sertraline mainly used in different social phobia, it is used in post-traumatic stress disorder, it is used in depression associated with anxiety. In those cases, sertraline can be used. It is usually given as a morning dose. Citalopram and its congener escitalopram. Escitalopram is more potent than the citalopram. Again, the adverse effects, the drug interactions are very less with this citalopram or escitalopram and very commonly used nowadays. Half-life is approximately 33 hours. Few days, we can see it is the preferred SSRI for mood disorder in premenstrual syndrome. It is also used in some anxiodepressive states, different types of the phobias or panic disorders also. Dapoxetine in SSRI, that is specifically indicated for the treatment of the premature ejaculation. Again, the premature ejaculation can happen due to some neurotic mechanisms. Here dapoxetine may be taken 1 hour before the sexual intercourse, and in those patients who mainly complains of this premature ejaculation can be benefited with this dapoxetine. Mainly it is used in these cases, but apart from this can also be used in depression cases also. So these are the adverse effects of the SSRI, like some gastrointestinal symptoms can be there, like nausea, vomiting, diarrhea can happen. Changes in the appetite, some weight loss or gain but less. Sleep disturbance can happen, then drowsiness with fluvoxamine, anxiety, tremors in some of the cases. Usually when we are starting with the SSRI treatment, for the first 2 to 3 weeks there may be some anxiety, but after that there will be decrease of the anxiodepressive states. There may be some sexual dysfunction also, like loss of libido, delayed ejaculation, that can happen with any type of the antidepressant drugs. Discontinuation syndrome may happen with some of the SSRIs, already we have seen. Drug interactions are less than that of the tricyclic antidepressants, but there are some drug interactions are there. These SSRIs should not be combined with MAO inhibitors or tricyclic antidepressants, already we have discussed. With MAO inhibitors, they mainly causes more availability of the serotonin, and that may lead to serotonin syndrome. That is, there may be tremors, hyperthermia, cardiovascular collapse and death can also happen. Both drugs usually require a washout period of 6 weeks before the administration of the other. For example, the patient is taking MAO inhibitor, now the patient will not responding to MAO inhibitor, we want to change it to SSRI. Then we have to stop the MAO inhibitor, and again approximately 6 weeks we have to start with the selective serotonin reuptake inhibitor. So washout period is needed approximately 6 weeks. Otherwise, if there is overlap, there may be chance of the serotonin syndrome. So remember, cheese reaction that may happen with the MAO inhibitor with the tyramine containing food, and serotonin syndrome that may happen when the MAO inhibitor is associated with the selective serotonin reuptake inhibitor. There are some newer ones like norepinephrine selective reuptake inhibitors or NRIs, like reboxetine and tomoxetine. Just remember the names, they are norepinephrine selective reuptake inhibitors. Apart from this, the advantage is they lack some antagonistic activity, the histaminergic, muscarinic, adrenergic receptors. That's why the adverse effects are less. Apart from this can also be used in depression, more or less similar efficacy. Okay. Next is SNRI, serotonin and noradrenaline reuptake inhibitors. So what is the difference with the tricyclic antidepressant? So tricyclic antidepressants also blocks the serotonin reuptake inhibitor, serotonin reuptake as well as the norepinephrine reuptake. But tricyclic antidepressants also blocks some other receptors also. They are blocking the alpha receptors, other 5-HT receptors, they are blocking the muscarinic receptors. That's why there are different types of the adverse reactions. But this SNRI, they are selectively blocking both the norepinephrine transporter as well as the serotonin transporter. So that's why serotonin and noradrenaline reuptake inhibitor SNRI, they are slightly more efficacious in some trials than the SSRI. So SSRI selectively blocks only the serotonin reuptake. Here SNRI selectively blocks both the serotonin and norepinephrine, while the tricyclic antidepressant non-selectively blocks both the norepinephrine reuptake as well as the serotonin reuptake and different other receptors. So this is the difference of mechanism of action between these different groups. So example is the Venlafaxine, desvenlafaxine, levomilnacipran and duloxetine, of which this duloxetine and venlafaxine very commonly used. They inhibit the reuptake of both serotonin and norepinephrine, already we have seen. Effective in treating depression in patients where the SSRIs are also ineffective. So we are giving the SSRI and the patient will not respond. In those cases we can give the SNRI. Sometimes effective in relieving pain associated with different other problems like diabetic peripheral neuropathy. Now remember, this duloxetine is now the drug of first choice for the treatment of diabetic neuropathy. Diabetic neuropathy, the first choice drug is the duloxetine. So apart from this duloxetine, venlafaxine can also be used in different other pain disorder, chronic pain disorder, fatigue disorder, fibromyalgia, this is also a pain disorder. In these cases, apart from depression, this is also the first choice drug, SNRI. Like low back pain, fibromyalgia, post-herpetic neuralgia, that is after the herpes zoster infection, there will be severe neuralgic pain. So this can also be treated by this SNRI. So SNRIs, unlike the tricyclic antidepressants, have little activities to other receptors. Already we have discussed, like little activity on the alpha muscarinic histaminergic receptors. That's why the adverse drug reactions are less. They may also precipitate a discontinuation syndrome. So we can see this is the site of action for the antidepressants. Already we have seen. So MAO inhibitors block the monoamine oxidase within the neurons, within the presynaptic neurons that is present within the mitochondrial outer membrane that blocks the metabolism and more availability of the norepinephrine and serotonin, and the reuptake is blocked non-selectively by the tricyclic antidepressants, selectively by the SSRI as well as the SNRI. So you can see the selective serotonin reuptake inhibitors like fluoxetine have no reuptake inhibition on the norepinephrine, but they are blocking the serotonin. While the venlafaxine and duloxetine, they are selectively blocking both the norepinephrine and serotonin. They are positive in both sides. Tricyclic antidepressants is very high, blocking this but non-selectively. They are blocking some other receptors also. So atypical antidepressants, some other antidepressants like norepinephrine and dopamine reuptake inhibitor NDRI. Example is the bupropion. Bupropion acts somewhat at different mechanisms. They are a class, special group of class. They have some excitant rather than sedative property. They are metabolized into amphetamine-like compounds, bupropion. Bupropion comes under group of norepinephrine and dopamine reuptake inhibitor. That is, they are blocking norepinephrine as well as the dopamine reuptake. Okay. So this bupropion is mainly useful for the cravings and attenuating withdrawal symptoms of nicotine in patients trying to quit smoking. So in case of the smoking cessation, usually we need the bupropion. Bupropion is given for a long period of the time so that there will be no craving for cigarette smoking. Bupropion can be used. Apart from this, bupropion can be added with other SSRI or tricyclic antidepressant if the patient is not responding, patient of major depressive illness. So this is an atypical antidepressant mainly used for the treatment of the smoking cessation, but it can be added with other antidepressant drugs for the treatment of the major depressive illness. The side effects may be dry mouth, sweating, nervousness, tremor, etc. metabolized by the cytochrome 2D6, contraindication, seizure or bipolar illness. This is more or less similar to all other antidepressant drugs. Just remember about this, that is, it is used in smoking cessation. Next is serotonin antagonist, serotonin 2 antagonist and reuptake inhibitors, also known as the SRI. Example is the trazodone and nefazodone. Trazodone and nefazodone, they are powerful 5-HT2A antagonists also. Okay. So they reduces the risks of anxiety, sedation and sexual dysfunction, and they can be also used for the treatment of the depression. But what happens, in most of the cases, they causes different types of the adverse effects. Like trazodone has been associated with priapism. priapism is a sustained painful erection of the penis that can happen, and that needs some surgical intervention. So that may happen with some trazodone. That's why it is lesser used nowadays. And nefazodone is withdrawn from the market due to the presence of the hepatotoxicity. That is, liver failure can happen with nefazodone. So this trazodone and nefazodone may be associated with priapism and hepatotoxicity. So there may be some orthostasis, dizziness can happen. They may be used. Apart from this, trazodone is also present in the market, that may be used for the management of the insomnia, because it is very much sedative. It is very much sedative. H1 blocking property is there. They may cause bradycardia rather than tachycardia, does not interfere with intracardiac conduction, less prone to cause arrhythmia and better suited for the elderly. It has been seen that the chances of the priapism in the elderly is less, and the chances of the cardiac arrhythmia is also less. That's why trazodone is used selectively in those elderly patients with depression who are not responding to SSRI or SNRI. We can give the trazodone. Okay. Next, coming to the mirtazapine. Mirtazapine also very commonly used. It is a sedating drug. It comes under group of the noradrenergic and specific serotonergic antidepressant. Mirtazapine mainly used in those angiodepressive states who have very sleeplessness, that is, there is severe insomnia, we can give the mirtazapine. They are also antagonists at the presynaptic HT receptor, they are antagonists at the 5-HT2 receptor. They are sedating because of its potent antihistaminic activity, but does not cause any anti-muscarinic action, that is, they do not have any anticholinergic action. Other adverse effects are very less. Only they causes sedation, and that can be utilized in those depressive patients who have very chances of the insomnia. Increased appetite and weight gain may happen. Markedly sedating, which may be an advantage in depressed patients having difficulty sleeping. That's why mirtazapine can be used in those patients. Depression which are difficulty sleeping, we can use the mirtazapine commonly in young patients also, young elderly, in all those patients. Mianserin also blocks the presynaptic alpha-2 receptors, antagonist at the 5-HT2, 5-HT1C, H1 receptors and different other receptors also. It is also sedative. Mainly it is used in different types of the panic attacks as well as the anxiety. There are anticholinergic and cardiac side effects, but it is less. But the problem of some blood dyscrasia and liver dysfunction are there. That's why this is also lesser used nowadays. Some blood dyscrasia, that is, the blood problems may there, and liver dysfunction may also happen. Tianeptine, it is increase rather than inhibit the serotonin uptake. It is neither sedative nor stimulant. It is seen. It is also may be useful in some angiodepressive state, some psychosomatic symptoms as well as endogenous depression. There may be some dry mouth, epigastric pain, etc. Just remember the name about this, tianeptine. Vilazodone, the newer ones. This is a serotonin reuptake inhibitor, 5-HT1A partial agonist. Again, the side effect profile, efficacy profile are more or less similar to that of the SSRI, but the mechanism of action is unique. Used again only in case of the depression. Remember the name, vilazodone. Vortioxetine, this is another newer ones, which is a combination of serotonin reuptake inhibition, 5-HT1A agonism, different other serotonergic antagonism. Again, it is also used for the treatment of the depression. Mainly these drugs are used when we are using the SSRI or SNRI, the patient will not respond, then we can use this vortioxetine, the miazenine, the vilazodone, etc. So next lastly coming to the therapeutic uses of the antidepressants. So antidepressants, already we have seen that is mainly used for the treatment of the endogenous or major depression. But already we have seen that apart from depression, it is used in several other conditions and it is very much beneficial in those. For example, it can be used in different types of the panic attacks or acute episode of the anxiety. Different panic attacks, these antidepressants can be useful. Generalized anxiety disorder, this can be useful. Obsessive compulsive disorder, very much useful. This is the mainstay of the drug. Attention deficit hyperactivity disorder, mainly it is seen in case of the children. Atomoxetine, which is another type of the antidepressant drug, atomoxetine, that is mainly used for the treatment of attention deficit hyperactivity disorder, ADHD, atomoxetine. Chronic neuropathic pains, different types of the neuropathic pains, antidepressants are the mainstay of the drug, of which, for example, post-herpetic neuralgia, or diabetic peripheral neuropathy. In those cases, the SNRI like Duloxetine is the first line drug. Fibromyalgia, it is also a chronic pain syndrome where we can use this. Premature ejaculation, already you have seen, again the antidepressant drugs are used. Different types of the eating disorder like bulimia nervosa or anorexia nervosa. You will read this. Anorexia nervosa can be seen in some models where they are not eating something to see for being more and more thin. Or bulimia nervosa, the patient is taking food but intentionally causing the vomiting so that there will be no weight gain. So these are mental disorder, anorexia nervosa, bulimia nervosa. Again in those cases we can use the antidepressant. Premenstrual dysphoric disorder, that is around the menstruation there may be some dysphoric disorder where we can also use the antidepressant drug. Aneurosis, aneurosis means bed waiting, that may be seen in case of the children greater than 5 years and also in case of the elderly. Here we can also use the antidepressant drug. Most commonly the imipramine. Imipramine is a tricyclic antidepressant that is mainly used for the treatment of the aneurosis, okay, bed waiting. Migraine, again the migraine, chronic migraine, we can use the antidepressant drug like amitriptyline. Amitriptyline is another tricyclic antidepressant that is used for a long period of time to decrease the frequency of the migraine attacks. Pruritus, in some cases of the pruritus, continuous itching, atopic itching, in those cases also there may be some psychosomatic components of this, that is why if we are using some antidepressant drug that also decrease the chances of the pruritus. So we can see if we are asked about the what are the usage of the antidepressants, antidepressants are not used only in case of the depression. It is used in several other disorders, all these disorders. Apart from this there is post-traumatic stress disorder also, there are other social phobias also. Apart from this is also several other conditions like kleptomania, that is intentional stealing of something. So these are the different types of the problems where these antidepressants are very much beneficial. So this is all about the antidepressant drugs. In the next class we will continue with the antipsychotic drugs and drugs for the bipolar disorder. Okay.